Good evening, everyone, and welcome to today's ILD MDM session. We have 5 unique and thought-provoking cases today, several with genetic problems, and it will be a truly a multidisciplinary approach because we have pediatric genetic department, Dr. Dhanya, with us. We have Bhavin sir for radiology insights and Ritu ma'am for pathology perspectives. And our esteemed pulmonologist panel is Rajan sir, Prahlad Prabhu Desai sir, and Murli Mohan sir. I welcome to all the delegates who have joined for this meeting. There are 5 cases. The first case will be by me. And there are 2 cases by Dr. Ashwati from KIMS Trivandrum, and there are 2 cases by Dr. Shobha, HOD Pulmonary Medicine, Amrita. So thank you once again, and let's begin here with first case. I'll start sharing my screen. Okay. So this is a story of a 29-year-old girl. She is 29 now. When I started seeing her, it was in 2015. So most probably she was 19 years old, or she was born of a consanguineous marriage. She is non-case of systemic sclerosis with all the features of skin thickening, Raynaud phenomenon, ILD, cutaneous vasculitis, and calcinosis cutis. That all the things started for last 4 years. This much of symptoms started for last 4 years. She is a diagnosed case of Werner syndrome, and we will see that what is Werner's in a short while. And she was also found to have this. This didn't happen in this way. She was diagnosed to have systemic sclerosis, ILD, in the childhood, and Werner's came in a later stage, and I will allow Mithun to talk about her because she's primarily Mithun's patient. And on she was treated with pulse cyclophosphamide from July 2012. She had a sister who also had Werner's syndrome. So when she is coming to me for last 10 years, and I just do her pulmonary function test and other assessment, and she develops recurrent infection, which also I take care. So she comes to me with significant weight loss and cough, and this all the features which I already suggested for systemic sclerosis. She has 98% room air saturation, and other vitals were stable. This is her other profile. ANA was strongly positive. RNP was also strongly positive. Taken in 2012. I have not repeated it. Other parameters, HB was 10.9. And this is, so before I give it to Dhanya, I would like Mithun to tell something about her.
Okay.
Yeah.
Actually, this patient, her disease started at the age of 13 years. She was initially treated by our pediatric rheumatologist, Dr. Suma Balan. Then only in 2017, I started seeing her. I think before Shana has also seen the patient. It is a typical case of scleroderma, juvenile scleroderma we call, and with ILD, Raynaud's phenomenon, and calcinosis cutis. However, later on what happened was the patient was doing well, and ILD, she was on mycophenolate meftil, and ILD was well controlled, like we can say. Initially there was some worsening, then followed by stabilized. She had very significant atopic dermatitis, and we changed the mycophenolate to tofastinib for atopic dermatitis in between. At that time, her sister also came to me with similar complaints, saying that these type of skin lesions. However, that was not scleroderma. She has uncontrolled diabetes, juvenile onset diabetes, and she was referred to our genetics department for further evaluation because her look was also a little different, very aged looking. At the age of 20 years, she was looking very like a 40-year-old. And from our genetics department, only first diagnosed Werner syndrome in her sister. Then the Ashwati Gopal was later diagnosed as Werner syndrome. That was the story.
Yeah, yes. I'll just show this. Yeah, Dhanya, you can start talking.
Yeah, so in this case, actually, we had first seen the, I think we had first seen the elder
sister, yes.
No, we had first seen the younger one.
Younger one, okay.
So actually, this girl had come with a history of diabetes from the age of around 20 years, and she was on insulin since then. And also there was history of hypothyroidism detected at 20 years. And also she had history of bilateral cataract also by 20 years, for which she had undergone cataract removal and IOL implantation by 21 years. And as Midun sir told, she had features which are resembling scleroderma, but she had a lot of poikilodermatous lesions all over the skin, which are certain classical features of Werner syndrome. So that's how we went on with testing her for a progeroid group of disorders, and that's how her Werner syndrome was confirmed. And she was found, and Werner being an autosomal recessive disorder, she was found to have, she did not have a mutation. Instead of that, she was having a huge deletion, which involved around 4 exons of the WRN gene. And then we went back to check her elder sister, and that's how the elder sister was diagnosed to have Werner. But one thing is that this interstitial lung disease as such is not explained in Werner syndrome. I didn't find any reports or anything.
The sister is actually having, elder sister is having scleroderma. Younger sister was also was worked up for scleroderma with ANA profile. Everything was negative. Therefore, this may be unrelated two diseases, scleroderma plus Werner syndrome.
Okay, so basically the reason we included Dhanya was to find out that Werner's can have association with this kind of systemic sclerosis or not. So as we can see, we have a serial PFTs taken since 2012 to 2025. And I would say it is almost status quo. She has some exacerbation when she becomes very sick, like in 2024, when tofacitinib was going on, she came with exacerbation and her saturation, she desaturated to 88%. That was the only time she was maximum sick I can remember. That was the time when she started losing weight, and we started thinking of doing something for her more than what we were doing. And I will give the screen to Bhavin sir for showing the CT scan, how bad is the lung.
Okay, so I've loaded all the scans here, and you can see the first scan is from July 12. Then we have Feb 13, March 16, November 24. And there's subtle disease even in 12 and 13, very subtle reticular opacities, subpleural sparing. It's a classic NSIP pattern. There is esophageal dilatation, and the MPA has always been a little dilated. But if you come now to 2000 and you come to November 24. I think November 24 is not hers. 1 second. Yeah. This is somebody else's. Give me 1 second. AG. I don't seem to have. Okay. It seems to have got lost somewhere. But nevertheless, it's just a little further increase in the pathology. So that's kind of what we have. So what we see here, that let's just imagine another 10% progression of disease that she has over the last 10 years. So that's basically where we are. And what I will do is I'll just see if I can search for this, and then once I can, I will come back to you. But this is the pattern. It's mild disease of scleroderma. Yeah.
So, sir, what I wanted to ask is, this is a second case which we are seeing, because this is longitudinal fall-off from 2012 to 2024, almost 12 years, and there is no significant progression, right? So for last
there is progression, but it's mild progression.
10%. That's what you said, right?
Yeah.
So that is what. So basically, the CTD ILD diseases not all develop. This is like systemic sclerosis ILD. Now, Mithun, if you can comment about the treatment part, because you were telling why we changed to tofacitinib. Cyclophosphamide was the first drug, steroid and cyclo.
She received cyclophosphamide initially by pediatric. Actually, initially she was treated with methotrexate for the skin from the Pariyara Medical College. Then when she came to Amarda, it was changed to mycophenolate mofetil for the ILD. And cyclophosphamide, initially cyclophosphamide, then followed by mycophenolate mofetil. And when she was with me, she was around for 1 to 2 years. She was on microfenolate, but she had this atopic dermatitis, very severe atopic dermatitis. The JAK inhibitors have been used for this atopic dermatitis, and for the atopic dermatitis, actually we introduced tofastatin, not for the ILD part. ILD we thought it is gone into remission. That's why we started tofa with excellent response to atopic dermatitis. Her skin lesions completely improved with tofa. Later on, actually, because of there is some desaturation, we again shifted the tofa back to microfenolate moftil after discussing with you, Dr.
Yeah,
Asmita.
yeah. I remember that it was stopped and she had some disease. I think that is the time when we did a CT scan also, like December 24. That's
Yes,
what I
yes,
was
yes,
right.
yes,
Yeah.
yes, yes.
November, December 24. So this is the case of Werner syndrome. The reason we brought it up is like sometimes two totally not related diseases can coexist. So the questions to the panel is, would MMF, he has stopped, she is presently on Bilipsa, which is for fatty liver. She had derangement of liver function test. So presently she is not on any immunomodulators for her interstitial lung disease part, but which has progressed hardly 10% in last 12 years. So would MMF or rituximab be preferred as a maintenance therapy in this patient who has combined this disease, and given her age and stable extrapulmonary status, with like should we consider her for lung transplant? But she has genetic disease. So I really just wanted input from the panel about both, because in such cases, do you refer for transplant? Anybody can take.
Patient is hardly symptomatic.
Yeah, but when we see her, we feel that her like she's getting old compared
That
to her
is,
age. Yeah, 29 years is not what we look like, what she looks like. Yeah. Yes, Murli sir, please. I think you can
No,
mute.
so two things. I think she does not need a lung transplant at this point, as both of you have emphasized. She's been very stable.
Okay.
Her other physical features do not, do not constitute an indication.
Suppose if she was requiring, is it like that is what? So if lifespan is 40, 50 years, we would still not consider, right? Because
No,
she
we could. I mean, if she develops a very severe lung disease at 35, when
okay.
we talk about a median survival of 5 years, the expected survival to 50 is not going to be a contraindication. I would be
Okay.
quite happy to advise, let whatever remaining part of her life be there, be as comfortable as possible.
Okay.
So,
I just want to add something here from a philosophical perspective,
Yes, sir.
that I don't think we can play God in terms of
Okay.
lifespan. Look at what happened to
Yeah.
cystic fibrosis. You never
Yeah.
expected them to live beyond 35, 40. Now they're going to live another 20, 30 years. The poor guys don't know what to do with their lives because they never planned to live that long, so they never got themselves educated or did all that normal people do, right? So you can't do this. For
Okay.
all you know, in
Agreed.
15 years the
Agreed.
landscape may change.
Yeah.
For scleroderma, for Werner's, you may get a genetic infusion antibiotic that could work against the gene. We don't know,
Sure.
therefore we can't take those decisions on behalf of the
Yeah, you are
patient.
right.
I'm
You are right.
sorry.
Danya, there was something which I read on the this thing that there is something called CRISPR or something which you can. So this deleted genes cannot be replaced. CRISPR kind of thing.
Usually, CRISPR, we use it, I think, mainly for single gene mutations. As such, I have not read anything about CRISPR being used for Werner syndrome, and
Okay.
specifically, this child has what? Sorry, not a child.
Yeah, girl. Yeah, whatever.
Yeah, girl. She has a homozygous deletion of multiple exons. So I don't know.
Okay,
Maybe in the
not an option
future.
for.
Maybe in the future. I don't know.
Sure.
so what have you all measured the telomeres in these?
I have taken the sample. I will do
You
that.
have. Okay.
I will take the sample. That I confirmed that we have. Unfortunately, we do not have a like. That's what I confirmed with Mithun also, that we do not have. Look, this all genetic test, na sir, it's very expensive. So we did for the children, but we don't have parents profile, and there is a consanguinity. So most probably they are carriers. So I don't know what is the status of the parents, and these are all real life cases. It's not like ideal situation. I don't have why I didn't check, because they can't
as
check.
with the parents, we have checked. Okay, both of them are
Okay.
carriers.
They are carriers. Both of them are
They are
carriers.
carriers.
Okay.
They are.
Okay. Okay.
So,
Fine.
Dhanya, can I just ask you one question?
Yes,
How
sir.
do you tell a patient about CRISPR, and what do you tell them? And two is, how do you counsel this lady if she had to marry or siblings, and when you do this kind of testing?
Sir, actually, till now we have never come across a situation where we had to talk about CRISPR to a patient. That's one thing. So, as such, I don't have
Because
an exposure.
most pulmonologists don't understand what is CRISPR, so you need to tell us as simply as possible.
It is actually a way of gene editing by which the area of the defective gene is being replaced by a normal gene. That is
Okay.
what is in simple, what
Sure.
I can say about CRISPR.
It works
Sure.
for cystic fibrosis, right?
Yeah.
Hmm.
Then I
Got
think
it.
that is for a specific mutation.
Yeah.
That's
Specific.
what I
Yeah.
understand. Yeah.
Correct.
So, as such, that's what I was saying, we have not come to a state where we have started talking about CRISPR to any of our patients.
Okay.
That's answer to your first question.
Right.
And then regarding how we counsel patients with Werner is once we get the report, actually these two are grown-up girls, and I think they are well educated also. So we actually had to directly explain to them regarding everything about Werner, because they were very eager to know what happens in Werner, and I think they had also read through Werner. So we had to just explain to them, and I don't know, they have never approached us regarding options of marriage or anything. And
But if they
in an
did,
ideal,
yeah, if they did, Dhanya,
yeah,
they
if
did.
they did, sir, then actually we should actually advise these girls to have a marriage very early, because the problem is that they can have ovarian dysfunction as
Okay.
time goes, because they can go for an early ovarian dysfunction, or if they are planning for a late marriage, probably we should give them options for oocyte storage, ovum
Sure.
storage, options for doing IVF. All these things will be explained to them. And this being a recessive disorder, if they marry a normal person, their children will be only carriers for the disease. Children will never be affected.
Yeah, that's what I wanted to know actually.
Yeah.
That's so important when you do genetic testing, right? When you about
Yeah.
counseling, that's
Yes.
that's
So
just
you have
wonderful.
to suggest the spouse, would be has to go for that testing before marriage, isn't it, Danya?
Very good. Yeah. Or usually it's very difficult in our Indian scenario for a person to do a genetic test and marry. So usually what we advise is that after they marry, they are advised to
Before
bring their
conceiving.
spouse to us,
Yeah.
and then we test the spouse
Yeah,
to see if he is also a carrier.
Yeah. Okay.
But she may want to test a prospective spouse, right? Before marriage.
Yeah. That I don't know. Most of our patients usually they come after marriage.
I think that
And then they
awareness has
bring.
increased, Dhanya, na? With Thal minor now, that has increased a lot.
But
Yeah.
sir, there is always, even if it's because it's a recessive disorder, there is only a 25% risk for the child to be affected.
Sure.
So most of them prefer to test their spouse, and if he's a carrier, to do a prenatal testing during pregnancy to check
Sure.
if the child is having the problem.
Got it.
Doctor,
Thank you.
So, sorry, I have very strong views on this because I do a lot of thalassemia work, right? Every day we do about 3 or 4 cardiac T2 for Thal. We've done maybe 6, 7,000 kids over the last 10 years. And it is distressing and disheartening that even in today's day and age, Thal major kids are being born. There is no reason in a country that claims to be what is it, the fourth largest rubbish GDP, whatever it is, to still have Thal major kids being born is like, my God, it makes no sense. And that is because of this. We don't test in advance. Thal minor kids know they are Thal minor, they still marry without testing. Thal majors, it's madness. they have to be tested in advance before marriage. And if you still decide to marry another thal minor, I mean, thal majors marry thal majors, and then, there's a whole lot of stuff, but that's okay. Then, you kind of do all the testing, but you have to test before marriage. You have to know. This is so important here. I mean, how can thal majors be born in 2025 and we still have them being born? I'm sorry, I just went off tangent, but
Yeah.
it affects you. You
Yeah.
can't have these new kids being.
Preventable
What
diseases.
I
It's
was just
just
trying to
not
bring out is
possible.
that however good your genetic lab is, and I'm sure it is, Dhanya, and we also work with a genetic lab, I think the counseling part has still to be, refined and improved significantly. That's what I feel, at least, that we've had those challenges and we're getting, better by the day, hopefully.
Yeah, at least we have started talking about it, sir.
Yeah,
That
that's
is
right.
because what when I did my MDM presentation, what I found is there are ILD MDMs only genetic ILD MDMs. They just discuss only genetics. So
Array,
maybe yeah.
so the standard rule, thumb rule now worldwide in the developed countries is that every ILD in a young patient below the age of 30, unless the patient has distinct connective tissue disease as an etiology, must get genetic testing done. It is a no-brainer.
Yeah.
We just don't do it. We
Just
have
wonder.
cohorts of kids, 20, 25-year-old. Everybody is labeled as HP.
Mm.
Everybody is
Yeah,
treated
yeah,
as HP. Nobody does genetic testing, and we're missing surfactant disease by the
mm,
barrel.
yeah,
But this is so important. It should just be a rule. In cardiac imaging, we do a lot of dilated cardiomyopathies, where now we know that a whole lot of these idiopathic DCMs are all genetic. And the rule is very simple. You have a dilated cardiomyopathy that is not because of triple vessel disease. You do genetic testing at any age. It's not even now young people. In ILD, it has to change now.
yes,
Every
yes.
young kid with ILD must get genetic testing done. I don't know why we don't do it. And it's not expensive. 10,000 rupees may
Yeah,
now. If you talk to Map My Genome and all these commercial people, you can take a deal with them, and in 10, 12,000 they do it here.
yeah.
That's affordable. Yeah, CT costs 8,000, 9,000. ऐसा थोड़ी है.
Yes, sir.
So,
I
I think it's a mindset. We just need to
yes, sir.
say that it needs to be done. Patient will get it done. So
Yeah,
that's
Prahlad Prabhu Desai, you, sir, you want to add something or we will move on? Yeah, we'll move on to the next case that is also from Kim's Trivandrum. Over to you, Ashwati.
Good evening, ma'am. This is actually a follow-up case from the previous MDD. This is the sibling of that previous patient who was diagnosed with Birt-Hogg-Dubé syndrome. Here is a 29-year-old lady who is an IT professional. She was referred to us from medical genetics department, and actively she did not have any respiratory symptoms. The only history she had was that of an allergic rhinitis with dust as a trigger, and a history of endometriosis for which she was on medications, and the condition was well controlled. On examination also she was stable. Her vitals were all stable, and chest showed normal breath sounds. And her sister was a proven case of FLCN gene mutation and Birt-Hogg-Dubé syndrome.
I think this I will ask Bhavin sir to talk first and then we will go to Dhanya. Yeah. You muted, sir? I can't hear.
so this fits in very well. And I just did this reconstruction that shows you the number of cysts that are there. So there are more than 10 for sure. And if you look at the cysts here, you'll see that they are ovoid, paramediastinal. This is classic Birt-Hogg-Dubé syndrome. And I mean, that's it. There's nothing else to it. There's no other coexistent thing. And whatever images I had, the patient doesn't have renal tumors or anything else. So that's pretty much it.
If I can ask you one question, sir. So if she is now only 29 years, so if I will do a repeat CT scan at 39 years, there is a chance that this cyst will keep on increasing.
Not a chance. They definitely will increase, yes.
Increase. Okay.
But that doesn't still mean anything because we have so many asymptomatic old people who have Birt-Hogg-Dubé where we've just incidentally picked up because they've come for other things in life. So
Okay.
it's not. Also, BHD, I think Dhanya will speak about this, but BHD is very different in India as compared to the Western world. We don't see those acne form lesions. The
Tumors?
tumors are much lower in incidence and
Okay.
prevalence, things like that. So,
Sure. So I think I will just share the screen and we can go ahead with the, yeah, Dhanya, you please, I think I have forwarded you both the reports, right? Of the index case as well as this case.
Yeah. So actually, I had first come across Birt-Hogg-Dubé around 3 years back. Actually, this was a patient who had come to us. He was an Ayurvedic doctor, and he had actually he had just gone for a screening for fatty liver. And when they did a CT abdomen, incidentally they had picked up some renal masses for him. And then they had done initially they had done an ultrasound and they detected this renal cyst, and he went for a CT abdomen, and CT abdomen detected cysts in the lower lung fields. So that is how he came to us with history of findings of multifocal renal tumors and cysts in the basal lung fields. And that time actually we were not aware of Birt-Hogg-Dubé, so we sent for and I think he had undergone a partial nephrectomy, and the histopathology had shown specific pathology in the renal tumor, which is a chromophobe variety of tumor, which is very specific of Birt-Hogg-Dubé. And then we sent for a whole exome, I think a cancer panel, and then we got the diagnosis of Birt-Hogg-Dubé. So actually the very classical feature or the major criteria for Birt-Hogg-Dubé is actually skin findings, which we often miss because they just resemble the normal skin tags, what you see in older people or very obese people. So often we tend to miss. So along with this skin findings, when you see this lung cysts and again multifocal renal tumors, that's when you you suspect Birt-Hogg-Dubé. Now regarding Birt-Hogg-Dubé, when I saw the mutation which these two children were having, this is one of the commonest mutations which are found associated with Birt-Hogg-Dubé. And an interesting thing about this mutation is that it has a very low risk for renal tumors. So they might not develop renal tumors in their life.
Okay, good.
So yeah.
So Dhanya, that's very interesting. What are the mutations? How many mutations are there in BHD?
Actually, there are the most common mutations. What they have described is one is this 1285 del C, and another one is 1285 duplication, dup C. These two are the commonest mutations that we find in Birt-Hogg-Dubé.
Okay.
And of this C.125 del C is specifically, they say that it has a very low risk for renal cell carcinoma.
Oh, that's great. No, this is so important for us to also know because
Sujit,
it's again
yeah.
Sorry.
But Sujit, this makes sense, right? Because all our patients of BHD, whether it's the first one from 2007 or the second one from 2015, and then the rest in between, hardly, except for the ones who had renal tumors to begin with and then were found to have Birt-Hogg-Dubé, all the ones who have Birt-Hogg-Dubé and you follow them up, nobody's landed up with any pathology. So maybe they have this particular mutation, which we should, but we should check, no?
Yeah, so that's why if I knew the mutation, Bhavin,
we could recheck.
What Dhanya mentioned, I could counsel them that, look, you're at lower risk.
That's very interesting, I must say. Thanks, Dhanya. Thank you.
Okay, I think let me see any questions they have put for you.
Dr. Asmita,
yes, sir.
Yeah, do we still screen them periodically for these tumors? Dhanya, what would you advise?
Sir, actually, what they say is that after 20 years of age, because that is the time when they have chance of developing renal tumors. So after 20 years, we advise a surveillance of an yearly MRI. Yearly MRI, because they often say that the ultrasound might miss small tumors which are less than 3 centimeters. So we always advise an MRI. And because it's a cancer predisposing genetic mutation, we don't advise CT because again there is chance of radiation exposure, and very rarely people can develop cancers in other glands like the parotid, the thyroid, and all. So we usually advise only an MRI. And if there is no family history of renal cell carcinoma, like if there is nobody else in the family affected with Birt-Hogg-Dubé, what the guidelines say is that if 3 consecutive MRIs are normal, then you can increase the frequency of MRIs to once in 3 years.
Decrease the
for any
frequency.
renal tumor. Decrease the frequency to once in 3 years.
Great.
So-
Thank you so much. Yeah.
So Danya, you said that once the patient becomes 20 years of age, you start screening them.
Yeah.
Yeah. Okay.
Yes.
Okay. Until what age? Like indefinitely. Okay.
Yeah.
Okay. Okay.
And what was the name of the mutation again? You said that was
C.1285.
C.1285. Yeah.
85
Okay.
del C. Yeah.
Del C. And duplication also has the same tendency of not developing tumors?
No, it is a deletion C that is associated with low risk for.
Okay, got it. Deletion. It's not the duplication. Okay. I think there are plenty of questions which they have put, whichever you people want to take. Surveillance method.
Go to the, they put questions on. Okay.
When do PFT and any role of screening to other parent? Danya, do you think the parent mother is negative, father, do we need to check? That's what they are asking.
Definitely, because there are 2 children affected in the family. So definitely one of the parents would be having the mutation.
So parent needs to be checked, right?
Definitely, yeah.
And probable prognosis, she already told. And is there any correlation between endometriosis? Danya, did you find it? Nothing, right?
No, I didn't find.
Okay. PFTs, Rajan sir, want to say
I
something?
think I would do it, if not go based on symptoms, Asmita. I think annual lung function is fine once they're stable, and if they have symptoms, maybe a little more frequently.
And Bhavin sir, if Danya is suggesting we should do MRI, can we do MRI lung also for cyst, or you are very particular, you will see the progression on the CT chest?
I mean, for the lung, it has to be CT for cysts.
Okay.
But then again, this, and again, it's a topic for another day, but radiation does not cause cancer. And it's a myth. And I don't think we should keep saying that until we get proof from a longitudinal prospective study that it does. So if at all there is risk, it's 1 in 10,000, which is really not a risk at all. But it's something that has gone into everybody's heads that it does. And so, we just keep saying it blindly. Doing an MR for a whole body is a 45-minute involved process that takes a lot of bandwidth, time, and effort. Whereas a CT takes literally 3 to 4 minutes to do. And so we still suggest that if you have to screen, you should do something that is simpler, easier, quicker, faster, cheaper, rather than bothering and wasting time. Do you know a whole body MR? We do it for specific instances like chronic non-bacterial osteitis, multiple myeloma in some instances, but to constantly keep doing MRs is a big strain on the system as well. So, and it's horrendously expensive. A whole body MR costs 25,000. It takes about an hour. A CT takes 5 minutes, can cost anywhere between 4 to 8,000.
And the one question they have asked, sorry. Yes, sir, go on.
No, that's it. I'm done.
Interval between each scan, sir. That is first question. Surveillance, how do you? So you don't want MRI, CT scan, how frequently, sir?
For what?
For BHD?
That's what, surveillance.
Sujit can answer. He's got a large number of patients.
So we follow them up on lung function. Honestly, every year doing a scan is probably not required if their lung functions are stable, but I'd say once in a couple of years is a good idea to do it. There's no standard guidelines, and I think you have to go from one patient to another. Prahlad, do you have any view on them? You're muted.
3-4 patients.
Yes.
And I don't think every time CT scan is required. A small cyst that takes some time to.
Yeah. And most of them don't progress too much. They remain stable. They develop a pneumothorax, we get a pleurodesis done. Yeah.
Okay. I think that was a very good information. Anything, Ashwati, you want to ask, or I will move on to the third case?
Thank you.
Thank you. Thank you. Just stay with us. I will give you a case because Danya has to go by 5:45. I will take the third case, which is also requires some genetic discussion.
Okay, ma'am.
Shobha, madam.
Yes. Good evening. I'm discussing 51-year-old male patient who belongs to Kasargod. He has no comorbidities. He works in Oman. He does office job. He's not a smoker. His complaint started about 12 months back with history of non-productive cough, which is intermittent and aggravated at night. He also had dyspnea on exertion, which has progressed from grade 1 to 2 in the last 1 year. And there is no exposure history. There is a family history. 2 children, both of them were male, who died at the age of 8 months and 18 months due to progressive muscle weakness. That's what the wife told me after we finished all the consultation and all the discussions. They also told me that father's brother had died at the age of 80 with a diagnosis of interstitial lung disease. Father's sister also had interstitial lung disease and she died at the age of 65. And there is no family history of asthma, no history of COVID infection, no history of skin rashes or any joint pains. He was actually evaluated in an outside hospital and he underwent a CT test in February, which confirmed.
Yeah, sir has got some images. Yeah. Bhavin sir.
Wait, sorry, I'm not getting the share thing here. Huh. Okay, so the first CT that you can see here, I think that's the February one.
Yes.
And what I'm feeling really kicked about is that it came as a video and I was able to convert it into a DICOM format and use it in OSI-RIGS. But you can clearly see that there are reticular opacities, traction bronchiectasis, subpleural basal predominance. It's a classic probable UIP pattern. With the, obviously we need to look for etiologies, but if no etiology is found, then that would be IPF. And then you have the July scan, which shows pretty much the same thing. So it's just that he is 51 years old, which is very young for this diagnosis. And so I guess that's where the genetic component comes in. But pattern wise, it's a probable UIP pattern.
Yeah. So, madam, you can ask questions to Danya and then she can answer because we don't have any test to discuss.
I want to know whether a genetic testing at this stage will be helpful for my patient.
Ma'am, actually, we have not been seeing a lot of patients with interstitial lung disease for whom we have done genetic tests.
Okay.
Probably we can try or we can start doing if patient starts coming to us, because usually for interstitial lung disease, we don't get any referral for any genetic test. Only for children, for recurrent infections or recurrent pneumonia, we are doing testing. But for interstitial lung disease, unless there is an associated immunodeficiency, we are usually not seeing any patients with pure interstitial lung disease who are coming to us for a genetic test. Probably we can try and find out whether how the yield would be like.
So I asked the same question, ma'am, because I think we discussed this case around 2 weeks before. And that time I asked the molecular biologist whom I am sending this short telomere. So she also told that whole exome sequencing is what you have to do for, because you wanted to know which genetic test to be sent, because we have no idea about how the other family members, which disease they had. So she suggested whole exome sequencing. That is what.
Okay.
But why would you do whole exome sequencing if you had a telomerase or a surfactant genetic mutation?
So telomerase and this, like, I think because we don't know, sir. That is why she told. Like, either you can go step by. This is like we don't have any idea what's going on. So she told that if you want to find out, and
So if you don't get a mutation,
yeah,
one of the mutations, then you do the WES, right? That's, I mean, I would imagine. Yeah, Murli?
I think here the problem is the muscle weakness.
Yeah.
Reported.
There were 2 children, yeah.
Together.
2 babies died.
And
That
did this
is also-
patient have early graying of the hair, Shobha, or a liver issue?
No, there is no graying. There
Liver
is
problems?
No liver problems, and there is no pancytopenia or any of the penias also is not there.
Disgrace, yes,
All
yeah,
is-
disgrace.
all-
And
yeah.
no volume redistribution, Bhavin, on the scans in the liver either, right?
Let me check. No, nothing.
I think I will have the lung function test.
Yeah, I'll show, ma'am. I'll show. Just a second. So, Bhavin sir, in this was a February 25, ma'am. February 25 and this CT, both are status quo, sir, right? There is no progression. Okay.
There's no.
So this is the lung function, ma'am.
Yeah, so it's more or less preserved. FVC is 76, DLCO is slightly on the lower side, 56, TLC is 74, and he has got a very much normal 6-minute walk test, no desaturation.
So I think this patient merits a biopsy. But anyway, let's hear the whole thing, Shobha.
Yeah, I went ahead with the blood tests. We did the CTD profile. Everything was negative.
Yeah.
Yeah. So, ma'am wants to know genetic study we covered. And Danya, if you want to leave, thank you so much. Your inputs are really appreciated, and I will trouble you when we have got. Please be with us and help us out in this. Thank you so much.
Thank you very much. Yeah.
So, Dhanya, do you do telomerase and surfactant gene mutations, Dhanya?
Sir, actually, we don't have an in-house facility for doing telomerase.
Okay.
And as such, now we are doing only whole exome in our hospital. We have not started doing any specific panels for specific diseases.
But we do whole exome at very competitive price, right?
Whole exome can be done. That's why. So because panel, again, the cost of the panel comes to almost the same.
Yeah.
So we have not started panel testing. Yeah.
So how much is a whole exome cost, Asmita?
It's around 20,000.
20,000. Okay.
Yeah.
The advantage of doing a whole exome sequencing, Sujit, I always feel is people pick up things that are specific to Indian populations. We're relying on certain panels.
Yeah. I agree because this is a patient. If I didn't pick up a mutation, I mean, this patient would head towards biopsy for sure. I mean, is young, 51-year-old with a probable UIP pattern should be biopsied. In my view, Shobha, there's no negative CTD workup, no genetic mutation. Should go for a biopsy, I feel. Prahlad?
Why, sir? Because what do you expect in the biopsy which will help us in the management part, sir?
I don't expect anything. I would do a biopsy. There's nothing to expect. Because if I see a biopsy that is typical of IPF or UIP pathology, I would treat this patient as IPF. And if I saw anything else, lymphoid follicles or anything, a lot of features going against IPF, then I would consider immunomodulation. Prahlad?
No, I think such a classical UIP pattern, why biopsy?
It's not classical, it's probable. No? That's what Bhavin said.
But probable is just the way they've used the adjective. I mean, it is UIP for all practical purposes. It's just that the honeycombing isn't there. But give it a little time and the honeycombing will also turn up. It's just, but this is what we would basically call UIP, IPF.
Only one thing, when you're taking a whole genome sequencing.
Little louder, Prahlad.
When we ask for a whole genome, few patients have asked actually, but you don't understand anything by that whole genome sequencing report when it comes to in the hand actually. And what you're going to do with that report. So I think
you have to ask the geneticists to do it.
For them also it is difficult to tell actually, honestly.
Is it? No, that's their job, right? Reading the whole exome and finding out.
With ILD I'm talking. Okay.
Yeah. So Lakshmikant has written that the chronic HP. Ma'am, what was his profession? And you would have taken, right? Yeah.
He's an accountant. There is no exposure to any birds or any other outside fumes.
You asked, right?
Anything.
Yeah.
Yeah, I have presented it. Yeah, I have written.
You told that.
Yeah.
And the consensus ILD diagnosis, do we have consensus?
I don't know, Prahlad and Murli, would you biopsy or not biopsy, Prahlad?
No, I don't think biopsy is required.
You wouldn't biopsy, Murli?
I think Murli sir, we lost, or
No, he's muted.
just unmute, sir.
Yeah, no, I was somehow.
Okay.
So I had to take it. So I think this is a probable UIP. As Bhavin said, given a little time, it's going to become a definite UIP. I would spend time ruling out the other causes rather than doing a biopsy. And if I don't find an underlying cause, then maybe I would consider biopsy. But I'd first look for other things, rule them out, call it IPF, and then take a call.
And we will not start antifibrotic?
Antifibrotic will start, no? Why
Okay.
No, but he's 51. I would do at least a bronchoalveolar lavage, I think.
Okay.
Shobha, because if he has a lot of lymphocytes, Lakshmi also felt there could be a possibility of HP. At least get a lavage done. What do you all feel?
This is not like an HP at all to my mind. So
I know. But you think a BAL could help here, Murli, or?
Sorry?
Because, I mean, you're committing a 51-year-old to a diagnosis of IPF is a little...
No, committing him to a of UIP, and we will work up and make sure there is nothing else contributing.
Yeah.
Which means then you need a biopsy. I'm just trying to think.
Yeah, first he told that first start working up the other things, and then if required, go ahead with the biopsy. So
but Shobha's done everything.
If I can
Shobha's
add
done a lot. Shobha's
yeah, I think Ritu madam wants to add something. Biopsy
yes, I
supporter.
really want to. I want to.
You, that is somebody.
For two reasons. That we could do a lot on the I mean, there are guidelines. I'm agreeing to that, but we could do a lot on the biopsy, including testing for surfactants just by using immunohistochemistry. We could take the genetic material from the biopsy and run it for specific genes, which we are considering right now. The panel was considering the telomerase and the other TERT genes.
Okay.
So we could do a lot, but unfortunately we have those guidelines which say that they don't need to biopsy. So that's sad actually.
No, the guidelines don't say that. The guidelines don't say that. At 50, they don't say that.
Not at 50.
Guidelines say for 70 plus. At 50, it is an MDM decision. That's a very clear thing.
So I could do the surfactant protein on IHC. I have the antibody. I've done it before for Dr. Pradeep had sent me a biopsy from
But
Bombay.
when you have a blood test, which is less invasive for checking the same thing, why would you subject the patient?
Madam, again, you would have the whole exome and so much of data.
No, surfactant protein mutation is there or not, you can check by doing genetic analysis.
So I'm just saying the situation hypothetical that the gene mutations come negative, as Lakshmi has put on the chat. UIP is a pattern, it's not a diagnosis.
We all agree with that. That's clear. The point is work out the other causes and then...
Yeah. Madam, any other question you want to put or we will move?
See, I have started the patient on antifibrotics and he has gone back to his job. So what advice should I give? Should I wait for a few months before deciding a call on biopsy or what should I do?
Yeah, I don't think once you've started an antifibrotic, Shobha, you've taken that call. So you can still do a biopsy, of course, but that's if you change your mind, I guess now. I mean,
okay.
So the working diagnosis of yours is IPF, but with, to me, a low level of confidence, I think, at this stage. I mean, or moderate. You could put moderate maybe because
moderate
40 to 60% of such patients turn out IPF. A lot of them don't.
One question, Bhavin, I want to ask you that geriatric age in India is much lesser than the Western geriatric age.
Correct.
So we see a lot of IPF at this age also. Right?
Yeah.
Yeah, but the thing is that at this age, irrespective, I think there would be some underlying etiology.
Etiology.
You know, commonest would be connective tissue disease, or it's familial, or there is some smoking
So
history
there
or
is a
something.
familial, na? Says, look,
Family, yeah,
father's
there is
brother
family.
died at 80, sister died at 65, and there is
Yeah.
some genetic predisposition is the
So then
word
all the
used
more
now.
reason to
Yeah.
do the genetic testing.
Yes, yes.
And in fact, today, Prahlad, if you when you get that genetics report, just put it in Claude or Chat GPT and ask it to give you an analysis for the specific question that you have, it will do it. I did it on my whole exome, and I had a specific question related to my ApoE for dementia. It clearly told me that it's not there because it went through everything and it was able to decipher it because I mean, that's its job. That's what an
Yeah,
LLM does.
sure.
So I think we can you take the help of that when we faced with those reports as well. I've done it with histopath slides also. It works. So.
Okay.
Yeah. Okay, I think move on to the fourth case. Ashwati, over to you.
Good evening, everyone. Today I'm presenting a 63-year-old male who was a retired high-rank police officer. He was referred from the executive checkup for his lung findings. The doctor there found something abnormal, so he had referred him. This patient was totally asymptomatic and he had good exercise tolerance. He used to cycle for 6 kilometers, jog or run for 10 kilometers on alternate days. He had a history of cough 3 months ago. After that, he was asymptomatic. There was no wheezing, no loss of appetite, no loss of weight, no dyspnea on exertion. He had a pet dog at home, to which he's not very close to, and there's a pigeon breeding area near his home, but there's no close contact. He doesn't go near that area. No history of drug abuse or any other high risk behavior. He had a history of coronary inferior wall MI, for which PCA was done. He's an hypertensive and diabetic on medications for the same. There's a history of post-COVID COVID infection in 2021, but there was no hypoxia, there was no lung involvement, the CT, everything was normal. On examination of the chest, there was bilateral basal velcro crepitations. There were no features of any other rheumatological diseases. There was no significant family history pertaining to the lung, only of CAD, CV, and hypertension was there. PFT was done. First of all, 6-minute walk test, which was normal. And this is the lung function assessment, which showed a reduction in the diffusion capacity. And the lung volumes were, compared to the initial one and the second lung function, there's minimal changes. That's it. The first time when he came, it was in August 2024. Along with that, we had done connective tissue disorder workup, ANA screening, RA factor, and anti-CCP, everything was negative. TCNA was positive, 2+. KU was borderline positive, and anti-DS DNA was negative. I'm going to the CT next.
Yeah. So PCNA 2+, Mithun, anything you want to say?
PCNA alone positivity may not be, it's considered very specific for SLE. But however, if, we have seen PCNA positivity without any SLE features also. Therefore, if ANA is negative, no, in this patient,
Yes.
then we can consider it as a false positive.
Okay. Yeah, Bhavin sir.
Right, so this is an unusual ILD. I'll just run through the soft tissue windows. There's nothing significant except severe coronary artery calcification. But if you start and you look at the axial images, we've got this pattern of reticular opacities, but they run across vertically. And then there's this subpleural sparing that we see here. If you look at the coronal images, there is a very sharp margin between the normal and abnormal lung. So we use the term, while it's straight edge is the typical sign, it's sharp margin, sharp edges is what we're seeing here. And you can beautifully see the subpleural sparing on the sagittal images. There's no honeycombing. There's very subtle traction broncholectasis. There is ground glass accompanying the reticular opacities. And then there's nothing else in the upper and mid zone. So it's a lower lobe predominant pathology, perhaps an NSIP like pattern with features like the straight edge and sharp margins that we typically see with connective tissue disease. So my first diagnosis would have been CTD ILD. But I have a question. I don't think I picked this up in the This is November 24. How is the patient now?
The patient is still asymptomatic, sir, and he's due for
Okay.
his next CT. He doesn't have any symptoms, no cough, no dyspnea on exertion.
Okay. Because one thing worrying, if you see here, you see this what looks like septal thickening along with the reticular opacities. And then whenever you see something like this, you're worried about an infiltrative process because conditions like lymphoma, amyloidosis, of course, edema, but the patient is not in failure. Lymphangiectasia, all of those conditions that can present in this manner, but the patient would not be asymptomatic. So while those are radiologic differentials, they don't fit in. I guess what the condition that fits in the best would be a connective tissue disease ILD or some etiology based ILD. But this is where we are.
Okay. All this. So
Excellent.
questions. Yeah, questions.
The questions were what further needs to be done for this patient. He has an ILD, he's asymptomatic, he's physically very active, and he's not willing for lung biopsy.
Sure.
So there's no indication for an antifibrotic here, but I notice that your last lung function, November 24, was almost 20% more than August. So maybe one of those is wrong. It's 3.06 going to 3.74 vital capacity.
Yes.
So that's almost a normal lung function, except that the DLCO is slightly reduced. That was one thing. And the other thing was, is the scan also of November 24?
Yes, the scan is of November 2024.
So I would repeat his scan and his lung function now if he's asymptomatic, just to see if those shadows have gone,
Okay.
Could this be like a little pulmonary edema, Bhavin? Could that fit in here?
Not really, because
No.
it's got very edema would be upper lobes and lower lobes. This
Sure,
is
sure.
only lower lobes. Yeah.
Okay.
But I am actually worried, and I don't think, irrespective of the patient being asymptomatic and all of that, this can't really be left alone. But I think if we can do a scan now or within a month, if it remains the same, perhaps you could wait. But if it has progressed even a little bit, then we have justification to say that it needs workup. And for me, as a radiologist, this is the ideal case for a biopsy because it's indeterminate. We don't know what it is,
Sure.
therefore it
Sure.
needs a biopsy. That.
Yeah, but I think before that we need a fresh scan, Bhavin. It's almost 8 months now.
Yeah, we need a fresh scan and then.
Yeah.
Can I ask one question, sir? So can we do because you were talking about infiltrative disease, will doing a PET CT help us better than doing a simple CT?
Yes, it's always a good idea when you don't know what's going on to do a PET CT. I think we keep picking up stuff here and there. And within a PET CT, if you do it at a center that has a decent CT as part of the PET CT, they will do a good
CT
CT
as
if you
yeah.
tell them to. So you get both the things done at the same time. I agree with you. Yes.
Yeah. Okay.
That was going to be my suggestion also.
Yes,
the
sir.
next time we should do a PET CT. And I think every 3 months we should probably follow up with the lung functions to see if it is progressing. But certainly no role for antifibrotic right now.
Sure.
And you're going to have difficulty persuading him to take an antibiotic.
Take a biopsy. The main issue is he doesn't have any symptom and he's physically very active. So when we are
so that's key issue. That's a key issue actually. When you said that, I thought you should start with CT and then move to PET CT later, rather than go straight with the PET, because he's asymptomatic and he hasn't lost weight, nothing, right?
Yes, no weight loss, nothing. He's physically very active.
Okay.
So wouldn't that be the ideal time to do it before he becomes catch early?
I would do that. Yeah.
Okay, sir.
Okay, we will go to the last case by Shobha madam. Thank you, Ashwati, for presenting two interesting cases. Yeah.
Thank you, ma'am. Thank you.
Sure.
Yeah.
Yes, madam.
He is another 51-year-old male, no comorbidities. He is a manual laborer from Chertala, but he is a reformed smoker. He came with grade 1 dyspnea, which is not progressive in nature, but he was not at all bothered by his pulmonary symptoms for the last 6 months. He had low back pain and shoulder pain for the last 6 months. And what bothered him was his painful swelling of both feet for the last 3 months. He was worked up by a physician, and then he was sent to me because of the X-ray findings. His exposure history, he's a manual laborer and he was working with cement mainly for the last 10 years.
Okay, yeah, that's a good information. Okay.
And he has no family history of asthma, no history of COVID infection, no history of skin rashes. He was evaluated in outside hospital, seeing the X-ray. They did an HRCT, but I'm not sure whether it is
No, I think I gave now.
It's an outside CT.
Yeah, I gave the image.
Should I show it?
Yes, sir.
Yeah.
Please.
Okay, so very interesting. You've got a contrast study which shows non-necrotic lymph nodes. The subcarinal and bilateral hilar are classically enlarged. I mean, even in our country, this pattern of disease would suggest sarcoid. And then when we look at the lungs, we've got fissural nodules, perivascular nodules. All of these findings would typically could be consistent with sarcoid. We can see all of them here. Little unusual is the ground glass that we're seeing in the lower lobes, but patients with sarcoid have HP-like patterns, and you have these mixed patterns of disease that would occur. So I wouldn't be worried about that unless there is some other diagnosis that crops up from a clinical perspective. Given the fact that the lung findings are a little atypical, I would also, in my report, I would straight away say that this patient requires either a nodal biopsy or a lung biopsy or both together or whatever it is, preferably after a PET-CT. So that we know what the disease burden in the body is and if there are more superficial nodes that can be biopsied.
Yeah, I'm not sure whether those slides are incorporated here, but Ritu madam had seen the images, and if she can say us about that.
Oh, biopsy is done, is it?
Yeah. We did a transbronchial needle aspiration.
Oh,
Yeah.
very nice.
Okay. Yeah. And this was blind TBNA. I won't say anything, but this is called blind TBNA, which we used to do when EBUS was not available. Okay. Okay. From
Okay.
subcarinal.
Let's
I must say you got good yield on this.
Yes. Thank you. Yes, ma'am. Please go ahead.
Yes, so you got a very good yield on this blind TBNA, and we can see and appreciate two very well-defined granulomas which are non-caseating, and they are showing multinucleate giant cells also, but there is no evidence of caseation. So it's a granulomatous inflammation for sure.
But
Yes.
why I said interesting was madam's first impression was HP, and I think like I don't know how do you differentiate? You know better that how do you differentiate HP from sarcoid on granuloma? That's very tough task, right?
Ma'am, I've seen on sarcoid, when you have such fissural nodules, we get these very well-defined granulomas, tight granulomas, as we can appreciate. So we don't see them in HP. In HP, they are usually ill-defined, they're loose, and so that difficult to get on FNAC.
There's also reticulin, right, Ritu, around the granulomas in sarcoid?
Yes, but sadly we can't do it on the FNAC smears because FNAC smears are just one or two in number.
No, I did transbronchial lung biopsy also, but that came inconclusive. Fortunately, this showed granuloma. So
no, biopsy also is granuloma.
Wow, good. I didn't follow that up. Okay.
Yeah.
Okay.
You can.
Okay.
Yeah, the slides are slide is not there, but
yeah. Okay, I didn't know that. Okay.
Congratulations, Asmita, for helping.
Thank you. Yeah. So we will go ahead with
both Dr. Bhavin and Dr. Ritu. Any other even mild features of silicosis, because he's had this exposure to cement for 10 years?
So I would definitely like to rule that out, sir, by putting it under the polarizing microscope. As ma'am said, they have the biopsy, so they can do it even now.
Yeah, we will send biopsy reports
Yeah.
also, ma'am. What do you want
Yes,
me
sir.
to tell pathologist, ma'am?
To do polarizing microscopy to rule out any silica crystals if present, and reticulin stain to confirm that the reticulin deposition is granuloma surrounding the granuloma.
So, two things about this. Number one is that there are no features. We'd get faint hyperdensity of lymph nodes, a little ring-like calcification, the early eggshell, nodules of differing sizes. Let me just show the CT again. I thought I was showing it, right? So you can see here that there are none of those features that we would get with silica or exposure. And the nodules are also the same, almost the same size. So, silicosis, we get different size nodules. And here, this is not like PMF. PMF is more central and you get volume loss and things like that. The other interesting thing is that if you look at the literature, because there is a worldwide rise in the incidence of silicotic lung disease because of the use of granite and illegal mining, and I think if you check out some of the articles in 2025 from UK and Australia, migrant workers are indiscriminately asked to work and they are getting acute and chronic silicosis. There is also an increased incidence of sarcoidosis in patients who are exposed to silica.
And
So there is some causation effect there.
Yeah.
So I would just,
yes.
I think it's still sarcoid, but maybe the cement exposure is also kind of aggravating it. I don't.
We had a
That
case
was
called silicosarcoidosis for exactly these reasons, typical sarcoid features, but we were able to demonstrate silica granules under the polarizing microscope. So that's why I was, this.
actually in US after 9/11 there was increased incidence of firefighters who were there of sarcoidosis. That is why sir, what sir is saying is like because they were exposed to cement. It's kind of I don't know. So madam's spirometry, yeah.
Yeah, reasonably okay. FVC is 70%. Normal 6-minute walk test. Because he is from ESI, we could not get a clearance for DLCO. It has not been done. I think the blood investigations, all of them normal except the ACE level, which was high. That's all. And CTD workup was negative.
Yeah, so the questions are this. We all agree with sarcoid, right? Anybody?
100%.
Yeah, and degree of diagnosis 100%.
Murli has stuck his neck out on something. I never stick my neck out.
There is sarcoid. The question is what triggered it off. Could it be silicosis? I'm interested in that. But
So mentors have often told me to maintain the healthy level of skepticism whenever you see a granuloma, and always look for other causes as far as possible. We do. Do we have the TB cultures come back? Shobha?
Yeah.
They're negative.
AFB
Negative.
smear is negative.
Right.
And gene
No,
expert is
cultures.
negative.
Cultures.
2-week culture is also negative.
Right.
Final culture we'll get in 4 weeks. And I would like to ask, what is the relevance of BAL showing lot of neutrophils? If you go back to the BAL, Asmita.
Okay.
Yeah. Neutrophil predominant cellular pattern. Does it
I
tell
don't know.
us anything about?
No, it's so the question is one, the cytologist, whether did he have an infection at the time you did the BAL?
Oh, no, he was perfectly fine.
Which means it's a little odd that you should get only neutrophils in the BAL. Should be more lymphocytes. And if you can do flow cytometry, you should be able to even differentiate those lymphocytes. But getting only neutrophils in a sarcoid case, Prahlad, you do more BAL than I do.
No. This is
No,
not.
no.
He's
Was
a
it hemorrhage?
non-smoker. If it would have been a smoker, we could have thought of it, but he's a non-smoker.
Yes,
Or
ma'am.
was bowel hemorrhagic in
No,
gross?
not hemorrhagic. It was not hemorrhagic.
Right.
Not hemorrhagic.
It's a little odd that you have so many neutrophils. That's
Mm.
Was he on
Maybe
steroids at this point?
no.
Yeah, I have started him on steroids
No,
and
no.
HCQ.
At the
so
time,
that's the tricky one. No? Now, yeah.
No.
go ahead.
You started now, na, ma'am, or you started
Now, after
now.
getting the results.
Okay, not before that. Otherwise, why would we do biopsy? Yeah, definitely not. Yeah, we did biopsy for confirmation. Yeah.
Yesterday only. I have started steroids yesterday only.
So Shobha, I wouldn't have started on steroids, and I'll tell you why. Because one is that this man has mainly joint pains. That's his main complaint.
He's also on HCQ. I have started HCQ also.
Correct. So he's on HCQ. He's got bad, painful. I want to know what Prahlad's view on this is, but bad, painful feet. Vital capacity is 70%. His exertional dyspnea is just grade 1. It's not too bad, right? So I'd give him a trial of methotrexate.
I would have.
Oh, yeah. Like
instead of prednisolone. Prahlad?
I think
Sir, one thing I will add.
Yes, Mithun.
Even the patient will be put
sir.
on hydroxychloroquine and symptomatic treatment rather than putting steroid or even methotrexate. We can wait, na?
I think he's got pain on HCQS. Am I right, Shobha? Or
yes, that's right.
That's the reason I thought.
How severe is the pain?
Yeah, he has swelling
So
and
there,
it's painful.
have you worked up for other organs like eyes?
I check up his painting. He doesn't have any symptoms.
Calcium, 24 urinary calcium, etc.
Calcium is normal. Liver function is normal. ECG is normal. All those workups are all negative.
I think we can think about small dose of corticosteroids before rather than.
I have started only on small doses.
Till your AB cultures are available.
Yeah. So small dose. I mean, we need to be clear here that based
20
on
milligram,
the
20 milligram.
20 milligram.
Sarcot, on the Sarcot study from Sejal, 20 is as good as 40.
40, yeah.
But there's also the Predmet study, which was presented at WASOG and has since been published, that methotrexate is as good. And Mithun was just saying something about that.
Sir, when these type of patients, when patient comes with ankle joint pain or feet pain, bilateral feet pain, there are two diseases basically. One is reactive arthritis and second is acute sarcoidosis.
Yeah.
Right.
Whenever you get, you will take a chest X-ray. If there is a chest X-ray findings with suggestive of sarcoidosis, then thing is that for joint pain, either you can give a local steroid injection or you can give a short course of oral steroids. Usually they will have a very good response to oral steroids. Short course, low dose means 15 or 20 milligram to the maximum.
So you're treating only joints, Mithun?
This is for the joint only. But when it is only Lofgren type, then you need not give other things. It will, a short course of steroids will help.
Lofgren's is the only condition when you do not even suggest biopsy, right, Mithun?
Yes. Guidelines say that even the classical X-ray picture or CT picture, you do not do a biopsy also.
Okay.
Suppose there would have been any joint pain, we wouldn't have treated also, Sweet, right? Na?
Yeah. We wouldn't actually, probably just got away with HCQS, but only thing Shobha mentioned that the pains were getting bad on HCQS.
HCQS is such a very mild type of, usually we don't give it as a monotherapy. Sure. Most of our conditions, we don't give it as a monotherapy. It's an add-on drug.
Got it. Sure. So for the lung, Shobha, we would usually look at symptoms and lung function. Very
lung
important.
Function?
Lung function I noticed was 70% vital capacity, but DLCO would be very important. If the DLCO...
But DLCO has not been done.
Correct. So that is important because you're committing these patients to 1 or 2 years of steroids once you start steroids, unless you have a plan to give steroids for 3 months and transition to methotrexate.
Yeah, that was my plan.
Right. In which case, which means if you're giving it 3 months, it's much longer than even what Mithun recommended. So
usually for acute sarcoidosis, we will look at only 4 weeks, 4 to 6 weeks.
That's right. That's right. So he's Mithun's talking about treating the joint.
Joints.
And if you're talking about treating the lung, 3 months, repeat lung function, you have gained something, get it off and get on to methotrexate. I think the side effects of steroid at his age, 51, would be, of concern, especially if he needs it long term.
Yeah.
Can we start methotrexate upfront? Usually, most of our diseases which require steroids more than 1 month, 2 months, we add a steroid sparing agent upfront.
Yeah.
Could probably methotrexate with steroids and taper the steroids.
Yes.
You could. I guess you could, Mithun. Yeah.
And we can replace HCQ now, because anyway it was not working.
It is not working.
But the question, Mithun, comes back to how aggressive is the initial treatment? What Prahlad was mentioning, he didn't even want methotrexate. Now we're giving steroids and metho, maybe a bit too much for this patient, So I think Shobha started steroids, well and good. Review at 3 months, I guess, as she planned.
Okay.
I think that plan is okay, and then try and transition to an alternative drug. Metho is first choice.
Okay. I think. Thank you, everybody. And the next meeting will be on 18th, right? 18th.
Very nice cases. Excellent discussion here.
Thank you, sir. Thank you, Bhavin, sir.
Thank you, everybody. See you.
Thank you. Bye-bye. Have a nice weekend.
Thank you.
You all too. Bye.
Bye.
Please give us these philosophical discourses. We welcome.
Okay, Ankit.
Okay, bye.
Bye.